So it is my pleasure and honor to introduce Dr. Maria Elena Perez. She is a licensed psychologist and the Vice President of Behavioral Health at 16th Street Clinic Community Center here in Milwaukee, Southside. And she attended the Northern Illinois University, where she earned her bachelor's degree in psychology in 1988. She later attended the University of Wisconsin-Milwaukee for her master's degree and educational psychologist, and then practiced in mental health in both inpatient and outpatient settings. She helped launch the Behavioral Health Department at 16th Street Community Health Center, which is the most popular or great center that we have here for the Hispanic community, has been forever, and he also attends many of the other cultures too, but is a place that definitely is a resource for our community. So she has a doctorate degree in psychology from Marquette University. And additionally, she has been an adjunct professor at Marquette University and had taught psychology courses at the Milwaukee Area Technical College, Waukesha County, and the Technical College at Lakeland University. She also performs psychological evaluations for the Latino community and has been on the governor-appointed Milwaukee County Mental Health Board since its inception. She's currently the vice president at the board and also chairs their finance committee. She's published in the Milwaukee Hispanic Journal of Behavioral Science and Journal of Counseling Psychologist, and she has been a public speaker on variety topics in mental health and has featured Telemundo's program, which is the Spanish-speaking channel that we all have access to. So I'll let you, Dr. Perez here, thank you for being with us. And if you want to share your screen, that will be great.
Can everybody hear me? Is everybody good? Awesome. Okay. And Narcinia, thank you for the introduction. And as I was telling you a few minutes ago, I'm so grateful. I'm just so grateful to be here, and just looking forward to the opportunity to sharing. And also, I mentioned to Narcinia that this is a very open process. So if a question pops up in your mind during my talk, feel free to share it in the chat. I know Narcinia has graciously offered to sort of be looking at those questions, because I want to make sure that I am responding to anything you might have on your mind. So as I understand, you are all Parent Center staff, so I'm sensitive to you as an audience. I know you are all a group of very impassioned workers and are very interested in the subject matter that I'm going to be presenting to you today. So I hope that it is a very valuable experience, and you will let me know what you need from me as we move forward here. So I'm going to go ahead and try to share my screen. Mind you, I'm a psychologist, not an expert in IT, but I think I got this. I think I got it. Let's take a look. Okay, I believe I'm sharing my screen, right?
That is correct. And if you want, you can now have it on the presenter mode or the full screen mode.
Okay.
It's at the bottom next to your volume. Did you?
Is it this
that
way?
little button. And there you go. Well,
do I have it?
Let's go back. I'm sorry.
No, that's okay. That's okay. I'll get it right. We're going to get it right.
We see your what you're seeing now. So
okay.
Try to exit. I will say
exit this one. Stop sharing.
That mode, or that little X that you have in there. I think.
Okay.
Do you see where your cursor is?
Yes. X. Oops.
Well, let's try again. And then I'll tell you, or we can just see on your side, that's the outline, that's okay.
Okay, so I'm gonna share my screen again, yes. Right? Okay,
just move the cursor, it's gonna be at the bottom.
Okay, I'm just looking and seeing where my presentation went.
Oh, maybe you have to open it again, go ahead.
quickly. One moment. Let me just get this going here.
No problem.
Okay. Okay. I've opened it, and now I'm going to go ahead and share my screen, and I'm going to click on it, and should be showing up for you momentarily. Is that right?
Yes, we can see it now.
Perfect, perfect. Okay, so I'm going to go ahead, and if it's okay, I'm going to go ahead and do like a slideshow version. That way I've got your wonderful faces on my margin, and I've got the presentation. Is everybody comfortable with the way that it looks? Okay, so we're here today to talk about obviously immigrant families, and specifically how we come to understand from a variety of perspectives these immigrant families and the needs they come into our settings with. Specifically, how trauma starts to play a role in the way that we view the needs of these families. So that's why we're here to talk. That's what we're here to talk about this morning. And I think it's a very important topic because as you know, there's an incline of immigrant families, and we really need to be, those of us like you who are front facing, really need to understand the role of trauma in the lives of these families, and specifically the children that we serve. So with that said, let me just see if I can get it going to the next slide. Okay, advance to the next. Okay. Is this okay? Okay. So I'm hoping that by the end of this morning, I think we're set to end right around 12:20, 12:30 Central Time. Come to understand, how does trauma might look like? How does it look like? Sorry about the typo in there. In immigrant populations, you know, trauma looks very different depending upon contextual factors, and certainly a person's country of origin plays a role in that. So we want to come to understand what that looks like, because there's a lot of potential for misunderstanding and mislabeling, if you will. So we really want to understand that. We want to understand the effects of trauma on these children, how we can use this information and work effectively with these families, because I know you who do the work in the trenches, you want to be effective with these families. And part of that is really understanding what trauma looks like. And what does it take to serve these families and be part of change? None of us here are doing this work idly. We all want to be a part of change. So that is really important to me as part of what we want to learn here this morning. And to that effect, I want us all to walk away with a greater knowledge set, not only knowledge, because I'm willing to bet that a lot of people in this audience have a lot of knowledge already. You guys are doing the work already. So it's not only the knowledge, but also what does it take? What kinds of skills do we need as we interface with these families? And maybe just equally as important is awareness. And I'm not talking about just awareness and how, you know, we know in the textbook, right? What we learn in our webinars, what we learn in any readings that we do. It's about self-awareness. And I think that we have to be very self-aware if we are going to be making an impact with these families. We want to examine our own assumptions about immigrant families, because as you know, if we're not self-aware and we're not tapping into that knowledge base, we're going to make a whole lot of wrong assumptions, and that could really get us into trouble and make us ineffectual, which is the opposite of what we need. We're going to walk away with more knowledge about trauma, what it is, what it looks like across a wide variety of groups, and the impact of socio-political and socioeconomic factors. I don't think we can talk about immigrant families and trauma without really understanding that a lot of these families come from different socio-political backgrounds, and the role of poverty and the role of all those important social determinants of health and mental health. So we're going to talk a little bit about that as well. How trauma impacts our work, both unseen and seen variables of trauma. how we build relationships with these families, eliminating power differentials, because we know a lot of these families have a good reason to not trust systems. And if we can do our part in eliminating or reducing that power differential, that often gets in the way of building trust. And we're going to talk a little bit about how to do that effectively, thereby addressing matters of race and prejudice, because we know that a lot of these immigrant families are subject to discrimination. So we'll talk a little bit about that as well. The importance of validating their experiences, that's utterly important, using different strategies, and also a little bit about gender roles and the spectrum of traditionalism, because a lot of our immigrant families they ascribe to more traditional gender roles and traditional values and beliefs and worldviews. So we have to roll that into our knowledge and our understanding as we work with these families. Okay. So who are these immigrant families? And I apologize for the small font that I used on this slide. Um, this data is taken from, I think it's the American Immigration Council. 1 in 7 U.S. residents is an immigrant, while 1 in 8 residents is native-born United States citizen with at least one immigrant parent. I was actually alarmed when I was doing research in preparation for this presentation. I think that the prevalence rates of immigrant families is underreported, not as understood as we want it to be, because by nature, I think that there are a lot of undocumented immigrant families. So we're not seeing the full magnitude of what these numbers really mean. In 2018, 44.7 million immigrants comprised 14% of the national population. So that's another thing to keep in mind. And I mentioned at the beginning of the presentation that these numbers are growing. So all the better reason to really understand these families and what their needs are. Okay. The top countries of origin for immigrants were Mexico, and that was the 2018 data, which is 25% of immigrants, India 6%, China 5%, the Philippines 4%, and El Salvador 3%. And again, there are various other subgroups that I'm not even mentioning here. So we have to keep that in mind as well. These are the reported numbers that we have as of 2018. 39.4 million people in the United States were native-born Americans who had at least one immigrant parent. So many of the United States and foreign-born children live in families with members who have mixed status, and by that I mean legal status. And I know legal status is going to probably come up this morning at least a couple of times. Some adults and or children are U.S. citizens, so this is a very heterogeneous, I think that's the way to say it, the heterogeneous group. They are a very diverse group. Others are lawful permanent residents or hold other types of lawful status through work and other visas. And then others have temporary status. So as I explain this to you, you start to get a sense in your mind of how diverse this group really is. Others lack lawful status, also known as that group of undocumented immigrant that I mentioned earlier. So again, what I want you to take away from this slide is really knowing just how diverse this population is. So now I want to talk a little bit about trauma and immigrants, because after all, that's what we're here to talk about. And I would be willing to bet that nearly all of you, if not all of you, have encountered trauma or traumatic experiences in the work that you do with these families. Now, when I talk about trauma, it's very easy to think about a traumatic event, like a car accident, like sexual violence, like domestic violence, and all of that is certainly part of that trauma spectrum. But I also want to talk a little bit about the other underscored elements of traumatic experiences, that of loss of identity and familiarity. Some of us would say, well, is that really traumatic? Well, think about it. You come from your country of origin and you enter a new country or a new culture, and you have just left your country of origin, perhaps even generations. So think about the loss of identity and clinging on to that familiarity. That can be very traumatic for a lot of our immigrant families. A lack of resources to help them cope in a new environment. Think about, not to mention the language barriers that a lot of these families come into the country with. And then think about the children of immigrants. They tend to show higher rates of anxiety and depression. That is a finding that has gone undisputed. That is a finding that has been consistent as we've begun to do more research on immigrant families. So think about that element of higher rates of mental health issues in these children as they enter our system. And then we have additional risk factors. What was their experience like entering this country? A lot of our families, certainly at 16th Street, have reported just horrific immigration experiences. Crossing the border, for example, a lot of women and children have reported to us that they have undergone maltreatment, abuse, rape, sexual improprieties, even in girls as young as the age of 9. So a lot of these immigration experiences are part of the fabric of these families as they enter into our borders, and they present to our clinics with a lot of symptoms of post-traumatic stress or other symptoms of anxiety, depression, and other mental health problems. We also know that there's an anti-immigration discrimination feeling or element to our culture, which further compounds the traumatic experiences that our immigrant families experience. And then let's talk about the history of civil war, of oppressive dictatorships in the countries that they come from. So they're already entering our systems with a history of traumatic experiences based on the nature of some of the elements of violence and oppression and war that are going on in their country of origin. I've already mentioned feeling estranged or, entering and feeling the loss of identity, but a lot of our families feel disconnected. They come estranged from family and country of origin. And let me make mention, I think that there's a misconception here that I want to just mention very quickly. A lot of people think that families come into the United States because they want a better life, right? Whatever that means, a better life, or they want to, advance their socioeconomic status. I have to tell you, we have encountered families, they didn't really want to leave their country of origin. And I'll give you an example very briefly. Back in the 60s in Cuba, those Cuban immigrants, they really would not have preferred to leave their country of origin, but they came anyway, not to improve their lives, because 1940s, 50s, they had a good life in Cuba, but then had to leave because of the oppressive dictatorship that took over in Cuba in late 1950s and early 60s. So sometimes it's not that they want to leave; it's just that they are. They're distraught about leaving, but they are leaving for other reasons other than, oh, let me just make a better life for myself in the United States, right? There are culture-related intergenerational conflicts that add to risk factors. And what I mean by that is, and we'll talk about this during the presentation, that, this is sometimes, traumatic experience sometimes is not just limited to the family that you have in front of you. There are traumatic experiences that have been going on from generation to generation, dating back maybe 30, 40, 50 years. So we'll talk a little bit about that transgenerational trauma that a lot of our families encounter. So now I just want to talk very briefly about acculturation stress. This is a word that maybe many of you are already familiar with. And this is a phenomenon that we have often witnessed in not only families, but in particularly the children. We know that, and first let me define acculturation. Acculturation is that process where a group of people or an individual, they come to a larger group, like the United States perhaps, and they have to adapt or they have to borrow traits from the dominant culture. So that is what I mean by acculturation. And what we have seen in children of immigrant families is they are often those that struggle with acculturation stress because they are the ones that are adopting the English language as they enter our school systems. They are the ones that have to translate for their parents. They are often the ones that have to do some adjusting to shifting their values because they come from families and countries of origin where the values are very different. The worldview is very different. The gender roles are very different. And here they're entering a new system where they're having to pivot and learn a brand new worldview. And that oftentimes puts these kids and these teenagers in a very difficult position. And they're often needing to navigate through that. And it's very stressful. We see a lot of kids in our clinic who come from families where they are really struggling with trying to fit into the new group, but they're still having to navigate through the values that they came into the country with. So acculturation stress is very real. And it really begs the question, who am I? These children are like saying, who am I? Who are we? Where do I fit in here? Because they literally have one foot in their country of origin and one foot in the new country that they are trying to assimilate and accommodate to. So immigrant families are already adjusting to a whole lot of change. They have to leave their country of origin. They have their customs and traditions. They have to navigate their family values and also carry with them those generations and generations of worldviews. So just put yourself in those shoes. And I know all of you do because you are front facing with a lot of these families. And it can be very difficult. It cannot be underreported just how challenging that is. There's a great pressure to assimilate, not only for these children, but these teenagers and these families. It's the process of assimilation is you know, they have already differing heritages and habits, and they have to embrace that new culture. So think about that challenge, right? And the pressure of them to assimilate into the dominant culture while their parents and their grandparents are urging them to maintain their values from the culture of origin. So you can already imagine children are already developing their identities. They're already going through a biological change in their brains. And think about that too. They're having to carry with them this burden of assimilation and accommodation and challenges with acculturation. I'm throwing a lot of vocabulary out at you, but they're already biologically dealing with their own identities. They are going through their own process of learning who they are and then having to carry that additional challenge of figuring out how they fit into their culture of origin and then their new culture. That's very, very challenging indeed. Furthermore, their country of origin may be experiencing collective trauma, such as war, oppression, economic hardship, and other forms of injustice. So we really know that there's, and I'm going to shift gears here very, very soon to talk to you all about intergenerational trauma or transgenerational trauma. You know, when you are sitting across from a family, you don't always, or I should say we all, none of us get the full picture, right? We see what they're coming to us with. And we're not getting the full picture. We're only getting a fraction of what's happening with that family or that child. And what I mean by that is we're just a fraction, because as part of the entire picture, they carry with them that history of what their country of origin is experiencing or has experienced. Many of our families that we have worked with are no stranger to having generations and generations of traumatic events that have been inflicted upon them. And this is sort of the best slide I can share with you, where you have that transmission of transgenerational trauma. And I've got, some of this is theoretical, but some of this is also biological. And I don't want to get too technical because that's not the kind of presentation that this is intended to be. But I wanted to just share with you that this is really a true phenomenon. We're learning more and more about the brain in neuroscience. And we know now that trauma, the field is called epigenetics, and I'll talk about that in a moment. We know that the brain, children are born with the capacity in their genes to have those genes express certain behaviors based upon the what's going on in the family or what has gone on in the generations previous. So truly, it's like carrying a backpack, and in that backpack, that child is carrying with them what happened 20, maybe 30 or 40 years ago. Because think about it, their parents are affected by the grandparents, who are affected by the great grandparents. Those behaviors, those parenting behaviors are transmitted down. So we cannot underestimate the effect of that. So while each generation of that family experiences its own form of trauma, okay, the first experience can be traced back decades. So we're learning more and more about this, and we really want to come into our experiences with these families knowing that you don't have the full picture. You're only having a fraction of the full picture, okay? So in that, I want to just differentiate between three types of trauma that we as psychologists see in our offices, and I am certain that you all have witnessed this as well. One type of trauma is acute trauma. Now think about acute trauma as maybe this is maybe it's a teenage girl, maybe she's 13 years old, and she's had a pretty normal family life, and she comes into the country and maybe for the first time in her life experiences racism, discrimination, prejudice. They make fun of her at school because she doesn't speak English very well, if at all, and they beat her up on the playground. Think about how traumatic that is. That, what I just described, would be an acute traumatic event, right? This is a 13-year-old girl who, by all other means or by all other measures, was fine until she entered the school system, and all of a sudden she's getting bullied. So that is an acute traumatic event, being bullied. Compare that to a chronic trauma, which is repeated, prolonged trauma, just like maybe a child being witness to domestic violence or abuse. Maybe that domestic violence happened in their country of origin, or maybe it's happening as they moved into their tia's house, their auntie. Maybe they are new to their auntie's house and they are witnessing the uncle and the aunt have domestic violence. And it's unrelenting and it's continuous. And not only that, maybe they have other traumatic experiences in their past. So that's, it starts to become more chronic because we see layers upon layers upon layers of traumatic events. And all of a sudden, it's not an acute traumatic event, it's a chronic traumatic event. And then the third type of trauma is complex trauma. And that is an individual who has experienced a variety and multiple traumatic events in their lives, often of an invasive interpersonal nature. So this is someone who has maybe come from a country in Central America, perhaps, and they were exposed not only to violence in their country, gun violence, drugs, maybe the challenges of economic hardship. Maybe it was a single parent home. Maybe they themselves witnessed and experienced sexual violence, and then coming into a new system where they have experienced further discrimination, poverty, poor housing, and language barrier. So as you can see, as I describe the situation, this becomes indicative of complex trauma. So I just wanted to share that with you guys because, again, it's good to know the different kinds, the different types of trauma. I know that these families are very complex, and in the spirit of helping them, it's very important to understand to what degree they've experienced hardship or trauma in their lives. So here, I just want to restate that trauma can be passed down through parenting practices, behavioral problems, violence, harmful substance use, and mental health issues. So those are all contributing factors that get passed down from generation to generation. And I think I promised you all a little bit about the brain, and I don't want to make this about this is not intended to be sort of like a brain presentation, but I really want you all to appreciate how much we're learning about trauma and the effects on the brain, and also this field of epigenetics. Now, epigenetics it's a study of how your behaviors and your environment can cause changes that affect the way your genes work. Okay, we're all born with genetic makeup, and epigenetics studies how behavior and environment interact together to affect how the genes work. So as we learn more, we know that our genes, it doesn't change our genetic makeup. What trauma does is it affects the expression of our genes due to the effects of the environment, because we know now that the environment affects the brain. It's not just that we're born into the world with a brain and our biology and our genes. Our environment and trauma impacts the genetic expression. So I wanted to just give you that little bit of science as a group of folks that you all are that are going to be working with these families, and as you learn what trauma looks like in children. So what does trauma look like in children? I've said that earlier in the beginning of the presentation, because I also mentioned trauma can look very different across different subgroups, because we know that there are differences, um, even if we look at the Hispanic or the Latino population, right? We know that we have a lot in common. We share a language, we share a lot in our cultures, but there are differences also across groups, depending on whether you're from Mexico, depending on whether you're from Cuba, El Salvador, Nicaragua, Costa Rica. There's different phenomena depending upon your country of origin. So I just want to shift gears here and talk a little bit about children specifically, because the children that you work with already have challenges, and I'm really wanting to make sure that I understand that the children that you see, the families that you see, already have children who already have challenges. No doubt about it. Maybe developmental disabilities, maybe autism, maybe other intellectual disabilities, mental health issues. So I understand that there might be other challenges that those children are presenting with. Put on top of that, these common symptoms that I have here on the slide in front of you. Symptoms of anxiety, depression, withdrawal. We know that children who have anxiety, some children with anxiety are very withdrawn, they're very quiet, they're very shy, they don't say anything. Whereas other children with anxiety might be fidgeting, okay? They might be just rocking back and forth in their chair. They need to get up out of their seat because they're highly anxious. They don't like to be around people. Without the proper knowledge, those children get labeled with ADHD. Those children get labeled as a behavior problem in the classroom, when in fact they might have anxiety. They might have an anxiety disorder. So that's why I wanted to bring this up, the other common symptoms. They might be acting out. How many of you could believe it if I told you that trauma in children, some of them are acting out? Some of them are becoming aggressive. Some of them are yelling and screaming and throwing things. And it's not necessarily that they are being naughty. It's that they are acting out, and they have been prone or exposed to traumatic events. Insomnia is very common in trauma among children, even among adults, to be honest with you. Insomnia is a key feature of trauma. Because not surprisingly, if you're in your bed and you're trying to fall asleep, but your brain it's hard to turn off your brain because you're thinking about past traumatic events. You're having what we call intrusive thoughts. You're worrying about tomorrow, or you're perseverating about the past. Maybe you're worried about something terrible that's going to happen in the middle of the night because that's what you experienced in your country of origin. Maybe you saw your mother getting raped in the middle of the night in your country of origin and nobody was there to protect her. And maybe you as a child, you felt powerless. So I'm giving you these examples because these are examples that unfortunately we at 16th Street, we've heard really terrible stories from the kids and teenagers that have come into our system to talk a little bit about what they've had to endure as they left their country to come here. Um, Overcompensating, I want to just say a word about that. Sometimes children, because they have gone through traumatic experiences, they will overcompensate. They will become like a little parent in their family. They will become a good boy, a good girl, whatever that means. And they will become so perfect, obsessed with perfectionism because they don't want to upset their parents. And they overcompensate by becoming parentified. And they all of a sudden have to be responsible for their little brothers and sisters. And that's very hard for an 8 or 9-year-old. I had an 8-year-old little girl from Mexico who was taking care of her 2 baby brothers. And she didn't have a choice. You know, I say that because as I resume my knowledge of the case or my memory of the case, she said that there was no way her mother could take care of her and the little boys because the mother was so afflicted by trauma and depression and substance abuse that this little 8-year-old girl had to step up to the plate and be the mom. So I just want to give you an example of what happens to children of trauma. They often overcompensate, or they become teenagers and adults who begin to drink alcohol or use other drugs. Some of these individuals become promiscuous because we know promiscuity can sometimes be a feature of trauma. As they try to numb their emotional experiences, and they unfortunately become promiscuous. In disproportionate anger, self-harm, cutting themselves. I know that some of the pictures that are on the slide show you a little bit about what these children experience. And in some rare instances, they can present with psychotic features, hearing voices and seeing things that other people don't see. So as you all see, those are common symptoms of trauma. And sometimes it's very hard to say, oh, this looks like trauma. This looks like PTSD, or this is clearly a traumatized individual. But we also know that it's not only their symptoms, it's also the effects of poverty, inadequate housing, single parent families. We know that single parent families have challenges that a dual parent family household don't have. Substance use problems I've already talked about, stress related to acculturation and discrimination, lower levels of education. We see higher rates of dropout and truancy among our families that that are immigrant families that come into our system. And then of course the cultural history of oppression that I have previously mentioned. So you think about these social determinants of health and how they compound the effects of stress on children who are already compromised. And we cannot underestimate the effects of poverty and housing and unemployment and single parent households. So these are the families that you are trying to help. These are the families you're trying to help. They have a lot of needs and they are very vulnerable. And so we want to just have our eyes wide open as we work with these families. We know that by nature, trauma is also characterized by extreme stress that overwhelms a person's ability to cope. I've seen, unfortunately, helpers that they mean well, right? I've worked with I train a lot of teams as part of my work as vice president of behavioral health. And some of my work in other agencies, including my own, there are a lot of people who mean well. And sometimes they've worked with these families and they have said, come on, you can do it. Ándale, échale gana, right? And sometimes that's not the right thing to say to the family at all, because maybe that family or that mother, they're already compromised in their ability to cope. They don't have the skills because they have experienced layers upon layers upon layers of trauma that has depleted depleted their minds because they have high levels of cortisol, which is that stress hormone. And over time, cortisol breaks down that person's ability to cope effectively. So it's really about helping the helper so that helpers can better understand and help the families that they're interfacing with. Also, there are no clear divisions between stress, trauma, and adaptation. How many of you know that there are families where they have been so used to trauma, they have been so used to stressful events in their lives that they just simply continue to adapt, they continue to cope, they continue to adjust. And before you know it, they don't even know that they are experiencing something very abnormal, something very maladaptive, because all they're used to doing is coping. And when you are adjusting over and over and over again, maladaptive patterns of trauma become normalized. So think about that as you help these families, because sometimes abnormal experiences unfortunately become very normal for these families. Which is very sad, because as I said earlier, the stress hormones start to really break down the body, and we see a lot of health problems, cardiac problems, higher rates of disease in families who live in poverty and trauma. So that's another finding that we don't have enough time to talk about in this presentation. Okay. So the effects of trauma, they affect the individual, they affect relationships, they affect human development, okay? They affect learning. I didn't even have that on the slide. I should have added that. They affect learning in children, because we know that traumatic experiences interfere with learning. And think about all of the learning disabilities or the IEPs that our kids and our teens are on. And how many of those children lag in their learning abilities because they lack sleep, they have insomnia, they have intrusive thoughts, they have hypervigilance as part of living in a traumatic situation. And so I should have added that right there to the slide. I forgot to add it, but effects on learning, certainly. And then we think about the costs to society, because if you are so afflicted by learning, by trauma, and you can't learn right, and your relationships are all affected by trauma, you can't rightfully contribute to society the way you know otherwise would be able to contribute to society, because you have a long history of trauma that's interfering with your functioning. Okay. Narcinia, I want to pause there just for a moment, and I want to see if there are any questions. Nothing seems to have come up in the chat yet, but I want to just take a pause and see if anybody has a reflection they would like to share with the group.
Yes, Dr. Perez, there actually, in the past 5 minutes, a bunch of comments in the chat. Do you want me to read them for you? They're just comments, but
I would love for you to read the comments, because that makes it engaging, and I want to make sure that I'm reflecting on the comments.
So I have very heartbreaking, but so true. It is so important for educators to be able to recognize these systems. Then we have Amanda, who says it's so easy for educators to go straight to labeling a child as behavioral problem instead of recognizing how trauma manifests. I often ask myself how we can get more schools to become trauma informed. Then we have Victoria that says yes, also educators don't realize. Then Jean is bringing up that she thinks that by having school personnel attend these meetings, she knows that they're so short staff and have their plates full. Then Emily says, I think as a society, we don't know what trauma means or looks like. This book from Oprah, she mentions, really helped me to understand how trauma manifests itself. And I also listened to that book, and it was very eye-opening. Let's see. I would love to see this as a focus for upcoming professional development opportunities. Trauma doesn't need to be in the past or from abroad. Today in this country, millions of children that are American citizens are living in the fear of seeing their parents being deported. The presenter would like to, if the presenter would like to include that. I have few schools in my area that are moving toward trauma-informed educating.
I
So
love that. Yeah.
yes, teachers don't know what they're aware of. And how many teachers will feel comfortable with it. Yeah, I think this is a comment from Deb. I remember at the beginning we talked about having cultural curiosity too, like it's nobody's fault, right? Like all of us see things differently. And we were addressing that in the previous presentation. So those are the comments we have, Dr. Perez.
Those are wonderful. Thank you, Nelsinia, for reading those. And thank you to the audience for reflecting some very thoughtful comments. And I love the comment about, children. We saw a lot of this a few years ago, where a lot of our children on Milwaukee South Side, were very afraid of their parents getting deported. That in and of itself, I mean, we had to respond to a lot of schools. And I just had a meeting this morning, and we at 16th Street Behavioral Health, we are now entering, I think it's like 11 schools. And you mentioned trauma-informed education, trauma-informed care, trauma-informed everything. I mean, we have to be trauma-led, and really, truly, cultural humility is part of this, and cultural curiosity. Those approaches are getting a lot of attention in the literature and in the research, and it's about time. It's about time, because those kinds of approaches are what's going to help educators and helpers really break down the walls and refrain from unintentional harm, right? We cause unintentional harm when we aren't being trauma informed, or utilizing those trauma-informed approaches. The behavioral health providers that I am sending to the schools right now on my teams, they are very happy to provide professional development activities with the teachers and the staff at the schools. We've talked a lot about the importance of, sort of leveraging the power, right? We have to leverage the opportunities we have to help those teachers, because those teachers are already overwhelmed, overworked. They have high numbers of children in their classroom. And it's not only the teachers, it's the office staff, the principal, the assistant principal, the secretary. So that is sort of like the multi-pronged approach that we are taking now, recognizing that you can be maybe not necessarily an educator, but you could be working in an office, and you yourself have to be trauma informed so that you don't unintentionally cause harm. So I really, really appreciate all of those comments, and welcome more, and thank you, because this really enriches the presentation, and will add to our conversation afterwards. So let's define trauma. And I've already been talking about trauma from different lenses. And I can tell you that the American Psychological Association defines trauma as the emotional response someone has to an extremely negative event. Now, if you think about that, you say, wow, then everybody's got trauma, right? Well, I have to tell you, in a way, we kind of all do. In a way, we trauma falls on a continuum. This is not something that either you have it or you don't. Trauma does fall on a continuum. And I want us to sort of get a broader understanding of trauma so that we can better zoom in the lens into our immigrant families, and we can better understand from that perspective as well. Trauma is a normal reaction to a horrible event, okay? The effects can be so severe that they interfere with an individual's ability to live a normal life. And again, I said it before, I am willing to bet that nearly everyone on this call or on this webinar knows someone who has gotten so who has gotten so affected by traumatic experiences that they're not coping well. Trauma affects relationships, work, academics, physical health, psychological functioning, and it really does interfere with quality of life. So that cannot be overstated enough. So let's know the difference between trauma, because I just got done saying that nearly all of us have experienced some form of trauma, right? If we're honest with ourselves. And again, that's a very loose definition, understanding that all of us have experienced a negative event. And, it's not what happens to us, it's our reaction to what happens to us that's most important, right? Some people cope very, I don't want to say very well, because that would be sort of like excluding people who don't cope well, right? Because traumatic reactions to trauma can vary very significantly. I could be a person who takes my traumatic experience and shoves it back in the back of her mind so that I can move forward with my life, right? Never dealing with that trauma in the back of my head. Okay. And maybe I look normal, but there's still that traumatic experience that I refuse to deal with. But maybe I develop alcoholism. Maybe I develop workaholism. Maybe I develop problems in my relationship and I'm very abrupt with my spouse and I'm yelling and I'm screaming and I don't even know where that's coming from, right? And that's what happens to some people who don't deal with trauma, right? So it affects nearly all of us, falls on a continuum, and it great variability across individuals, because there are people who are very resilient and they have hardy personalities and they've endured a lot of things. Like the gentleman I saw, this was a few years ago on the news, and his house was completely destroyed by a tornado. I don't know if any of you saw this. Completely destroyed his house, and I don't remember if something happened to his pet or whatever. And when he was interviewed on the camera, he was like, well, yeah, my house is gone, but homes can be rebuilt, but relationships can't. He was just like, you know, he had that approach to life that was like, okay, this terrible traumatic experience happened, but he seemed very centered and calm in the midst of a traumatic event. So I'm just wanting to point that out, because there are different reactions and there's great variability across individuals with respect to how people respond to traumatic events. Um, this is very different from what we call PTSD, or post-traumatic stress disorder. And again, I really wrestled. I have to tell you guys, I really wondered about whether or not I should even include some slides about post-traumatic stress disorder. The reason I'm including some slides about post-traumatic stress disorder is you would not believe how often this question gets asked anytime I do a presentation on trauma, whether it's about children or adults or interfacing with substance abuse. A lot of people ask me questions about post-traumatic stress disorder, and how could you really tell it's post-traumatic stress? Now, none of you on this webinar, I don't believe, are expected to do treatment for post-traumatic stress disorder, but I really want to tell you that it's important to know at least something about PTSD, because I know that all of you have seen it. All of you have seen it. The difference between trauma and PTSD is that PTSD is an actual psychological diagnosis, and the focus on PTSD is on treating it, and it causes clinically significant impairment or problems in the family. Like I said earlier, work, education or academics, your health, your psychological functioning, that is what gets affected by PTSD. That may not be the case with just trauma, right? Because like I said earlier, trauma is pretty insidious in our culture. Okay. So I just want to point that out and let you know that with post-traumatic stress, that can be, and again, I spoke earlier about how trauma can be an acute episode versus a chronic kind of condition versus a complex condition. And I promise you, I will take you back to your immigrant families, but I want you to understand a little bit about PTSD. With the diagnosis of PTSD, a person is exposed to a traumatic situation. It could be death, threatened death. So think about that. If you know a family who maybe experienced the police coming to their door with guns and they broke into the house in the middle of the night, a family might feel threatened and they might feel like, oh my God, there's imminent danger. There's somebody who's going to get injured or death, so that's usually the nature of the exposure. Okay, it's a direct exposure, or as is listed on number 2, witnessing a traumatic event. I wish I didn't have to tell you that children at our clinic, there are a lot of children who come to behavioral health and they report having witnessed domestic violence in their home. It's pretty common. Because we know that violence in the home, it doesn't have to be hitting. It can be verbal abuse as well. And unfortunately, verbal abuse is more common than we know or that we realize. So we know that also traumatic experiences can be observed indirectly by learning that your close relative or a close friend was exposed to trauma. So maybe I am a mother, and I learn that my sister back in Guatemala, maybe I'm learning that my sister experienced rape or another violent act. So maybe I didn't experience the traumatic event, but I learned that somebody that I love experienced a traumatic event back in my home country, and there was nothing I could do about it. And that becomes a symptom, right? And it could also be an accidental problem, but I'm just giving you an example of a violent situation because a lot of the examples I'm offering you this morning come from actual clinical practice. Repeated or extreme indirect exposure to aversive details. So some of you, and this is why I want to bring this up to this group in particular, some of you might have already been told by one of your families that they experienced a traumatic event. You might have had to hear details, vivid details of very horrible situations that the families have undergone. And so be careful. I want to talk to you at the very end of the presentation because we ourselves, as parent helpers, parent trainers, therapists, social workers, teachers, educators, we ourselves can develop PTSD because of listening to so many stories of traumatic experiences. So we have to be aware of that as well. When someone has PTSD or they might have PTSD, it's very common for them to have intrusive symptoms. And by intrusive symptoms, I mean like memories that keep popping into their minds. Children might experience intrusive symptoms by the way they play. I've certainly been in an art therapy room with a child who draws pictures of traumatic situations in their family, or maybe a memory that they actually went through. And so children express it sometimes during the way they play or the way they draw pictures. They can have nightmares, and I'm talking about adults too, not just children. What we call flashbacks. Sometimes those unwanted thoughts or memories intrude on the individual. And in some situations, people can experience dissociative reactions. So maybe some of your families that you've worked with have those flashbacks. Maybe they feel disconnected from their bodies. Maybe they actually feel separate from the situation, because we know that dissociation is when a person actually disconnects from their body so that they don't feel the intensity of that trauma. And that can happen with intense or prolonged distress. Anytime they are reminded of a traumatic experience, maybe they see something on the television, or they're in a waiting room at the clinic and they witness a fight, or they see something on the television. It could be any kind of trigger that can get that person to dissociate as a way to cope with the intensity of the unwanted memory. So there's a lot of physiological reactivity. Heart rate might go up, they might start to sweat, they might start to hyperventilate, or they might start to feel disconnected and numb. I don't know if anybody has ever seen that in a family member, where they literally feel, or they seem like they're not even in the room. They feel far, far away as you're talking to them. They don't even feel like they're there. And sometimes that's an indication that they are dissociating. What's also typical of PTSD is they avoid what reminds them of the traumatic experience. So we see that avoidance is part of post-traumatic stress disorder. It's not that they're necessarily being avoidant to be difficult or challenging. It's that they literally avoid unwanted thoughts or feelings related to the traumatic event that occurred previously, maybe in their country of origin, or maybe right here in the recently. And that could be a reminder of people, conversation, activities, a certain object, a certain smell. I had a woman who, she was in my office, and she, right in front of me, there was a smell of potpourri. And I don't know, it wasn't coming from my office. It was down the hallway. One of my therapists had some potpourri or an incense candle burning. And all of a sudden she was flooded with memories from her experience in the Dominican Republic. And she was first and foremost far, far away. And I had to bring her back. And she was then able to tell me some of the traumatic experiences that she was remembering as a result of that trigger of that smell that was coming down from the hallway into my office. So sometimes it can happen that way. So the mood sometimes is affected. I'm not going to go through each of these slides for the sake of time, because there's so much more that I know we can talk about. But sometimes there are negative alterations or changes in the way people think or their mood that's associated with the traumatic event. Or sometimes they have trouble remembering details of the traumatic event. And again, I wanted to talk to you about this because I want to make sure you guys maybe have recollections of someone you've worked with in the past. They may have been presenting with symptoms of PTSD and we didn't even know it. So the nature of this is that it's persistent, and maybe they have negative beliefs about themselves, because we know that traumatic experiences, especially with severe PTSD, affects a person's self-esteem. It affects everything about them until it resolves, right? Sometimes they can blame themselves inappropriately, or they blame other people that shouldn't even have the blame. Forgive me, it's a Spanish saying. Some of you who speak Spanish in the audience is los otros tienen que pagar los platos rotos. So other people have to pay the price for the broken dishes. It doesn't translate very well from Spanish to English, but it's another way of saying sometimes people who have gone through traumatic experiences, well-meaning people in their circle, pay the price. They're suffering the backlash of the trauma, and they're not even at fault for the traumatic experience, but that person who has undergone that trauma is sort of projecting that anger out at people who are innocent in their lives. And I'm sure that some of you can come up with some examples having witnessed that with some of the people you've encountered. And again, I'm sort of like going off track. I don't want to go off track much further, but again, with post-traumatic stress, it's more of a disorder, and the symptoms can affect a person's interest level. They become disinterested in things they used to be interested in. They feel alienated or detached from other people, and they feel sort of flat, or they don't express a whole lot of emotion. Some people, remember I said, become angry and they project onto other people as part of trauma, but other people do the opposite. They actually have a constricted affect, and they don't express a whole lot of emotions at all. So be aware of this, because I want you to see that there are many faces of trauma. Okay. And I've already talked about some of this, but the only thing I want to add is that that self-destructive or reckless behavior can also be part of PTSD. How many people look at self-destructive behavior as, oh, she's just cutting herself to get attention. Oh, she's just, she's just reckless. That means she has problems with the law. She probably just needs to get arrested. She probably needs to go to jail. You would not believe, when I used to work in the prison back in early 2005, 2006, I worked in the prison system, and I worked with a lot of minority populations, not necessarily immigrant families, but families who of the minority population who did a lot of reckless behaviors. And you would not believe the disproportionate number of inmates that I saw who had a diagnosis of PTSD, you know? And so there's this overlap of PTSD with reckless behavior and maybe illegal behaviors. So there's that whole Pandora's box that we could go on and talk about, which we don't have time to do. Hypervigilance, which means you're also always looking out the window, always waiting for something bad to happen when there might not be anything bad that's going to happen. How many families have you worked with where there's that paranoia, there's that startle response, they can't concentrate, and they're hypervigilant. They're always waiting for something bad to happen. And guess what? It's because they might have PTSD or they've endured experiences where something bad happened to them over and over and over again. So these are other criteria that I don't want to necessarily get into, but I want to fast forward to slide number 36 here, because I want us to talk a little bit about the dangers in mislabeling or misdiagnosing something that we don't understand necessarily. And this is why this is such a valuable webinar, because all of you are precious. All of you are doing such great work in being open and bold, because I think it takes courage to work with these very challenging families. And we have to be self-aware. We have to be aware of our own biases as we sit face to face in front of these families. We have to be self-aware enough to say, I have to be careful that I'm not mislabeling. I have to be careful that I'm not stigmatizing or misunderstanding something. I have to be careful that I'm not being judgmental, because we know being judgmental is something that happens when we don't understand something about a group. We just judge them because it's easier to judge something rather than to spend the time trying to understand. So what that leads to is it marginalizes the youth or the family that we're working. They're already marginalized. They're already facing discrimination. They're already facing trauma. They're already facing the adjustment coming into a new system or a new country. And the last thing they need is for people to misunderstand. And I have to tell you, this is very unfortunate. All too often, that is what's happening. People judge what they don't understand because they're not taking the time to self-reflect or learn about the group that they are trying to help. So it's very important. They're already at risk, so it's very important to be self-aware and learn as much as you can as you pursue more education about working with these families. We judge what we don't understand. I've already talked about, I've got my cursor on it, the cutting. Some of these pictures are, they're sad and they're disturbing. And you look at some of these pictures and it's easy to say, oh my gosh, what's going on here? This little boy is just sitting there in front of his schoolwork. He's not doing anything. He must be lazy. He must have a learning disability. He must just, his mother is probably not even feeding him. He's probably tired. His mother didn't put him to bed at a decent time last night. Okay, I'm giving you examples of what might come to someone's mind who is uninformed and judgmental. And how do I know this? I unfortunately have encountered people who have had thoughts like that and have said it out loud. People who don't know, they're ignorant, and they ignorant meaning they don't know. I'm not using it as an insult. They simply are just ignorant that this might be a child that is dealing with unresolved trauma. We don't know if he's not sleeping at home because of traumatic memories. We don't really know. So we have to take the time to really get to know the family, get to know what's going on there before we judge. Reserve judgment. Okay, this kid here at the bottom in front of the bus, he looks like he doesn't even want to get on the bus. So it's very easy for us to think, is this child truant? Is he just being a pain in the butt? Is he just not cooperating with his parents and the school? Okay, maybe there's something else going on. Maybe at home his stepfather is beating the mother, and he wants to stay at home because he wants to make sure mom is safe. Okay. Again, these are scenarios that I have encountered in the clinic. Okay. So think about that. And I'm not suggesting anybody here judges people, but I think that we all, including myself, we have to really, really be diligent about our beliefs about these families that we work with. So how do we become effective? We have to become willing to understand the worldview of the families that we work with. We have to be able to take a strength-based approach. Okay, every single family, every single child that we work with has strengths, every single one of them. And it's kind of like becoming a detective, right? You're all detectives, and your job as a detective is to identify their resilience. Find what is strong about their family. Find out what is the strength in this family, because every family has a strength. Every family, every youth has a strength. And your job is to find that strength so you can build upon that strength. Emphasize that relationship that they have with their family members. Validate how hard it must have been to adjust to a new system, how challenging it is to carry with them that immigration experience, and emphasize the strength in that and the relationships and your own relationship with that family. Identify and have that, what someone said in the conversation in the chat earlier, the cultural humility, cultural curiosity, evaluating that in yourself and the person or the families that you're working with, and being sensitive to those acculturation issues that we spoke of earlier in the beginning of the presentation. Perhaps the family has religious beliefs. You can use proverbs or cuentos. Maybe the family is responsive to other more traditional religious or spiritual beliefs. And if you yourself can learn a little bit about that and leverage those cuentos or those spiritual beliefs, maybe the family believes in a curandero or the use of other practices. Learning about those practices can really go a long way to bridging the relationship with those families. Sharing your own experiences. I have to tell you, sometimes having a PhD doesn't mean as much to the families that I've worked with as much as it means that I'm a mother. I'm a madre, I'm an abuela, I'm a esposa, and sometimes they look at me and they say, "Eres madre? Are you a mother?" They don't care about the PhD. They want to know if I'm a mother. They want to know my experiences they might even want to know a little bit more about me than I want to share, but guess what? I share it anyway. They want to know me as a person, not just la psicóloga, not just the psychologist. So be willing to share a little bit of your experience. Be bold, and sometimes that means more to these families than you can even imagine. Be supportive, be non-judgmental. Ask them for what they need from you, because they may not, nobody's ever maybe asked them, what do you need? How can I help you? Be willing to listen instead of thinking that you have all the answers, because guess what? They are willing to share. They are very willing to have that conversation if you just listen, if you ask and you listen. And remember that they are the experts in their family. They truly are. One more word about self-care, because I think that there's a lot of things, a lot of webinars, especially with COVID-19 last year. I presented a lot on self-care, a lot of different webinars that I did, a lot of talks last year. We as front-facing professionals or parents that work with these families, you all have to take care of yourself, because this is not easy work. This is not easy work. You're very passionate, and because you're passionate, that sometimes makes you more vulnerable, because your heart is out there on your sleeve. You have to care for yourself if you're going to serve these families. So we are more effective when we take care of ourselves. We have to have good boundaries. In other words, please know, we cannot save everybody. We can't save the world. We save one familia at a time, one individual at a time. and have good boundaries, because you have to take care of yourself. And you know, you have one family at a time, and that is really important for you to do the good work that you're doing, understanding you can't help everyone. Be a good role model. Sometimes parents are so stressed and they are not taking good care of themselves, and you yourself can use yourself as an example, use yourself as a tool, and be willing to talk about being a good role model, and maybe sharing some of the things that you do to take care of yourself. Very, very powerful. And remember that your impact on these families is greater when you yourself are healthy. So that is the end of my presentation, and I want to thank each and every one of you for allowing me to speak and giving me your attention. I really value your attention, and I know that we have about 15 minutes here, and I want to open the floor to have some thoughtful conversation and give you the opportunity to ask questions if you need to.
Thank you. Thank you for all the comments, and some of them come directly to me. If you want to or would like to show your video for this time too, that would be great. But I would like to take probably visually, like who wants to, or take the floor and ask the question. This is our time for asking those. I learn a lot myself. It's like, wow.
A lot just preparing it. I learn something new every day. And you know who the best teachers are? The families. They really teach us so much.
Go ahead.
Does anyone have any cases that they'd like to talk about? Maybe you've encountered a family and you're curious and maybe want an opportunity to ask a question or share with the group. I know Jesus, I see your hand up.
Thank you so much, Dr. Perez. This has been a wonderful presentation. I've been doing this for 26 years, almost 27. Wow. And everything that you have said is, I agree with you wholeheartedly. The question that I have is that lately, there's been an active move in linking historic trauma to current issues in schools for Native Americans. Is a different, it's hard because every trauma, it's hard to gauge the strength, how the impact of trauma, because it is such an individualized thing. It's terrible for every person. But in the case of Native Americans, there's a collective move now in recognizing what these peoples as ethnicity have suffered in their own country. So, but I also recognized all the trauma that our families that come from, all over the world to this country have to go through, including now the people from Afghanistan.
Yes.
How can we, is there a relation that can be done through the departments of education about recognizing the needs of immigrants also, without taking away from the historic trauma of the Native Americans?
Thank you, Jesus, for that fabulous question. I think if I'm hearing your question right, I listened to the very tail end of it about, is there something that can be done? I'll be the first here. I'm probably not the first to say it. I don't think there's enough being done. I don't think there is enough being done. But the good news is that means that there is opportunity to do more. But we really do need more grassroots efforts, more people, more advocates that are willing to, to do that work. And as you just pointed out, our friends, our families from Afghanistan now are here, and we're doing a lot of learning here at the 16th Street about, okay, we can anticipate that these families are going to need help too, right? And to your point, Jesus, about the historical trauma pertaining to the Native American families, we're just now learning more and more through neuroscience and epigenetics. It used to be thought that that's impossible. How can people carry trauma with them? from generation to generation. It wasn't making any sense, right? But now we're learning more about collective trauma. Historical trauma is the term that you just used, where it's not just the individual manifesting the trauma, it's the group of individuals. And this is the saddest part I want to mention here, because we know that many of our friends, our Native American, not of our Native American friends and families, but our African American populations, many of our African American family members and friends have spoken about slavery and how slavery has affected their collective identity, passed down from generation to generation. What hurts my heart, it's so painful to talk about. It hurts me anytime I hear someone say, oh, slavery, that was a very long time ago. That doesn't affect us today. That's gone. Why are you bringing that up? Well, newsflash, it's very relevant, because what we're learning now is that those experiences are carried down collectively from generation to generation. Epigenetics is going to show us more and more the genetic expression of populations that have undergone, undergone oppression and abuse and discrimination, right? Now, some might push back on that and resist. And, I'm not here to have a debate about politics or anything like that. But, we what we need to do, Jesus, is we need to take the charge of educating more and more. And I do believe it belongs not just in the education system. It needs to be infused in our policies and really having a very deliberate approach to policymaking and to education. And it does start, I think, at the macro level, and sometimes it has to start at the micro level, but obviously when we want to affect change, we have to have enough of that momentum to affect the larger systems. That's sort of a long-winded question. I'm not sure I answered you, but what you said there earlier, Jesus, was spot on.
Thank you, Dr. Perez.
So we have Tammy. She has a question. I'm sorry, I misspelled your name, Tammy. Next time I'll get it.
No, you're fine. And it was almost the same question. So maybe I could just expand on it a little bit more. Sure. So how do you, and this might be really broad, but how do you address when you have the group trauma or the race trauma, or the cultural trauma, I don't know what we're calling it, but that whole group trauma, how do you address that on top of those individual traumas that you're carrying? So is it a layered approach? Is it, I'm just curious. Does that make sense?
So I hope I'm hearing it correctly, because there's almost two approaches to the answer. One approach is, and I've certainly done this in my individual work with patients, with clients, where I have had African American clients talk to me about their mistrust of the system. And how, how do I know you're not going to call CPS? How do I know you're not going to take my kids away from me? And that morphs into a conversation about mistrust in the system. That morphs into a conversation about race and racism, and which could also morph into a conversation about historical trauma. I've actually had conversations with patients about that in the context of treating depression or bipolar disorder or substance use or whatever we're trying to treat, right? And if your question, Tammy, is about how do we address it, I can tell you that this in and of itself needs to be heard and validated. The worst thing we can do on an individual level is to invalidate a person's story or understanding of their narrative. That was her understanding of that narrative. So how do we address it? We address it head on. And far too many people are kind of scared to talk about race. They're afraid to talk about historical oppression because they don't want to offend anybody. But I say we need to really be bold, and we need to be vulnerable, and we need to be willing to have the conversation with people who have been historically oppressed. So that is how we might address it in an individual level, right? At the macro level, I really do believe it involves advocacy efforts and having the courage to have conversations out in the open, because I do believe people are really hungry to have that conversation. Because some people will say it, and maybe the group has been thinking it, but they were too afraid to talk about it, right? So I hope that answers the question. The combination of validating and affirming a person's historical trauma, and then being willing to take sort of that advocacy approach and open those conversations. Maybe
It
even
did.
yeah.
It did answer it, and you hit on the trust part too, which was a huge, that was a question inside of that. So yes, thank you so
Oh.
much.
Good, Tammy. Thank you.
Awesome. We have Marbella next.
Yes, thank you. Dr. Perez, I'm going to make a comment, but I also want to ask you a specific, if you can provide this. You mentioned about us being front-facing professionals. We listen to families, we go to their home, we see how they live. We become pretty much the safe line for them for everything, for every challenge that they encounter. I have families that have shared so much with me of those traumas that sometimes at the beginning of my career, I carried them. I was having trouble sleeping, just thinking about what these people went through. In your last slide, you mentioned about protecting ourselves. What recommendations? Because sometimes we can listen, but also we have to be very careful and not to practice. We're not therapists, we're not social workers, in my case. So what recommendations would you provide? Because obviously we deal with very hardcore situations. We're Monday reporters too, because if we see what's going on, and so, child abuse, domestic violence, this and that and that. So I'm sorry to throw all of this to you, but I just want to provide my staff with good practices from protecting ourselves from those red flags, and when we should refer that person to a professional, trained professional for mental illness, social work, anything else, and not be believing that we're Jesus Christ, that we're going to be saving everyone. Yeah. I hope that makes sense.
Oh, my bad. That's such a fantastic question, and thank you for highlighting this, because I'm certain you're not the only one. And bless your heart, because you've been doing this work a long time, and families trust you, all of you. And we carry trauma by hearing it. We call it vicarious trauma. That's the term that we use in the profession. We say vicarious trauma, and unfortunately, all too many of us carry that with us because we care so much, right? And so vicarious trauma can cause insomnia. Some of the things you just mentioned, Marbella. So to answer both of your questions, one has to do with how do we care for ourselves, specific strategies, right? And some of that was captured on that last slide about self-care, right? And knowing we can't save the world. And sometimes it helps to literally, at the end of the day, take an exhale and unpack what we just heard and put it on a shelf. My mother always taught me, because when I was young, I was probably in my 20s. I've been doing this work a very long time. And my mother would say to me, póngalo al lado, put it aside, because I would come home and I'd have a stomach ache, I'd get migraines, and Mommy, you wouldn't believe what I heard today. And she would literally give me my advice, my consejos, right? So I would say you really have to practice maybe a ritual to put it on a shelf, save it for tomorrow. If there's a practice you have to maybe put a protection in your mind around that family that you love and care for, maybe it's about putting them around a protection. If you're a person who uses prayer, you can pray for the family, but certainly find practices for yourself. That could be yoga, that could be prayer, that could be meditation. But certainly cognitively making that disconnect and having a ritual that you can disconnect from the work that you do each and every time, right? And then Marbella, you also said something else. What was the second part of your question?
Because we listen, families trust us, they come to us for everything pretty much. But when we have to be careful, not practicing or stepping into the role of a therapist or social worker or whatever.
Gotcha. And now I remember why I included those slides on post-traumatic stress disorder, because I want you guys to know that, you know, if you see that family or that individual is having persistent insomnia, disproportionate anger, they're having nightmares, flashbacks, they are describing to you that they are not functioning well. They can't work, or maybe it's a young person and their school is suffering academically. I would say that is when you refer to a professional, because now we're talking about clinically significant symptoms that need attention from a professional, that need direct treatment. And your role then becomes that of a supportive role. And like you said, a safety, because you guys are the safety net for these families. And that cannot be underestimated. I would say that in the families I've worked with, the families that have the kind of support that you give them are the families that do better, because there are families that don't have the benefit of anybody coming into their home to help them. Can you imagine? A lot of families don't have the support that you give them. So I would say if their symptoms are interfering with their interpersonal functioning, their job, their health, their academics, that is when you refer to a professional.
Do you have time for one more, Dr. Perez? I know she
I
has
do.
to go back with her patients and all that, so.
No, that's okay.
Okay,
Yeah.
Jane, you're next.
Thank you. Can you hear me?
Yes, Jane.
Okay, thank you. I enjoyed your presentation so much.
Thank you.
But I have a question. You mentioned that trauma can be, I forgot the term you used for it, where it passed on generation to generation. What was that
Yes.
term?
Transgenerational, transmission, intergenerational.
That was another word. I think it started with an A.
Are you thinking about are you thinking about epigenetics?
Yes, epigenetics.
Okay. Yeah.
Okay. So if that is a fact, how do you stop it if it happens on its own?
What a wonderful question. Oh, Jane, I love that question. And this is why, because that is a magical question. Thankfully, the brain, maybe you've heard of a term called neuroplasticity. And neuroplasticity is the brain's ability to change structurally and functionally as a result of experiences. So we know that people who have the support they need, people who get treatment when they need it, people who are validated and held in a safe space, that starts to resolve some of that trauma. And that is how you treat the intergenerational transmission. Okay. Now that sounds overly simplistic. It does sound overly simplistic, but we cannot underestimate the power of, think about it. If you have a mother who has post-traumatic stress disorder, she's seeing a therapist, but she's also having you in her home and really having that relationship with you and all the supports that you offer. She starts to resolve her trauma. She starts to resolve and understand and heal her grieving from many generations of abuse. She starts to sleep better. She starts to be a better mother. She starts to feel relief. She's going to start to feel better and parent her children better. Those children are going to feel better because their mother is doing better, because we know that children do only as good as their parent, right? Those children grow up in a healthier environment. They grow up to be parents. They start to raise their own families, and they start to heal the lineage of the intergenerational trauma. So it takes a couple of cycles, right? I think that is how you treat this problem, Jane. And I think that you also are free to parents about the power of healing right now and how that will affect the generations to come.
Okay.
I actually know families that have said that to me. They've said it to me in English. They've said it to me in Spanish. They've said, lo tengo que resolver. I have to resolve this. Mi nieto, my grandchildren need me to do better. And so there's sort of this intuitive recognition that healing ourselves is going to lead to a healed family. And that is going to benefit the generations. They want to break the cycle.
Okay, thank you. Thank you so much.
Welcome.
Okay, we got towards the end of the presentation. What I have to say is at least this last 5 minutes, my heart is warm I think that all of us, one way or the other, can relate to every of those questions and to our work. So I want to give you a big thanks for being here, for taking your time and volunteering your time to come and present to this.
The pleasure's mine.
And we're honored again to have you here. I hope it's not the first or the last time either. And it popped up as a brainstorming, like some key elements that we even didn't go to at all that we probably can, as a group, start developing in the next year, as we talked about it. So like vulnerability too, you know, it's like ourselves and why. So my last thought here for the group is practicing the curiosity, right? The cultural curiosity, like why Marbella is talking about this, what Jesus is saying that, why, if you don't understand it, we got to, there is a point that we can move on and then we can see what's on the other side. Just in case is what I thought, because all of us have so much different practices that it could be confusion, right? Like I wouldn't ever do that, but there got to be a reason like why the question was asked.
Yes. And Narcinia, I put my email in the chat because I want to welcome anybody who wants to send me an email, you know, with other questions or maybe seeking resources. They're certainly free to, you're all certainly free to connect with me.
Awesome. I'm going to finish the recording.